My name is Tommaso Addona. I take care of a great deal of patients that are diagnosed with breast cancer. My practice consists of predominantly breast patients, both on the reconstructive side as well as on the cosmetic side. I try to prepare a few slides, not to overwhelm everyone, but more just to generate conversation. And so 5 things that I think patients really should know going into options for reconstruction. So a lot of patients will often present to the office and ask, what are my options for reconstruction? Before we can get to that question, we actually have to step back for a second and say, well, what procedures are the best for you from the oncologic end? Often patients have either seen a medical oncology doc or a surgical oncology doc, and they're coming in with the understanding that they're having sometimes a biopsy, sometimes it's a lumpectomy, so a portion of the breast is being removed, and sometimes they're candidates for a mastectomy, the breast removed in its entirety. Right. In those circumstances, patients are consideration for. Some patients are candidates, or when they have a mastectomy, can undergo what's called a skin sparing mastectomy, which basically means the surgical oncology doc, the surgeon that's performing the mastectomy, is going to remove the minimal amount of skin, but it does include removing the nipple and the areola. And then there are some patients that are candidates for nipple and areola sparing mastectomy. And those patients have those preserved during the mastectomy, and those can sometimes influence our options for reconstruction. So the first bullet point, the first two really, oncoplastic reconstruction and contralateral symmetry procedure. If patients come in and they have a lump that needs to be removed, some patients do just fine having that lump removed with just the oncologist, meaning that you can have a plastic surgeon there. However, the plastic surgeon may not offer very much utility in terms of reshaping or recontouring the operated breast. So in those circumstances, what will often happen is the surgical oncology doc will do the procedure with the patient, and sometimes those patients follow up with us after to see if there's any opportunity. And sometimes they don't warrant any intervention from the plastic reconstructive side. However, there are patients where the amount of tissue being removed is a fair amount of tissue in the breast, and our surgical oncology colleagues feel a little limited in terms of their option to reshape and recontour the breast. So in those cases, we offer oncoplastic reconstruction. So what is oncoplastic? It's really exactly as it's spelled. There's the oncologic portion, where the surgeon that's performing the lumpectomy performs his or her procedure with the patient. Then there's our portion, the plastic portion. And plastic means to reshape in Greek, so plastikos. So our plastic reconstruction basically means we're able to reshape the breast in a manner such that we can do one of two goals, or achieve one of two goals. One is to try to create incisions or utilize methods where we can hide everything, so it's as though nothing has happened for the patient. Or number two is sometimes we can kind of improve upon things. And what do I mean by that? Sometimes patients may be candidates for a breast lift or a breast reduction. And in those circumstances, patients can have the lumpectomy performed at the same time as the reduction. So when it's all done and healed, it looks as though a patient only underwent a breast reduction or a breast lift, but they really did have an internal oncologic procedure. When we speak about contralateral symmetry surgery, that basically implies if a patient's experiencing a lumpectomy or a surgery on one side, they're entitled, and it's covered through insurance, to have the other side matched to the best that we can provide symmetry for the patient. Other options, when patients are considering undergoing a mastectomy, or it's something that the breast oncologist and the breast surgeon have recommended, in those cases, we have several options for helping to rebuild the breast. And again, this isn't meant to be a deep dive into all these items. It's really just meant to help inform patients that these are available. Of course, each of these bullets can be discussed ad nauseum, and since I love to speak, I'm happy to go ahead and do that for y'all. But implant-based reconstruction, or the patient's own tissue, autologous reconstruction, those are options we often apply for mastectomy. So mastectomy, in essence, if you think about it, it was described to me when I was a junior resident as, imagine a hard-boiled egg. the breast oncologist has to open the shell of the egg, remove the inner contents, the egg yolk and the egg white. So a mastectomy, in essence, has to remove the inner contents of the breast tissue, and the fat around that tissue. However, they leave or preserve the skin on the outside, as well as preserving, at times, the nipple and the areola. So it's an empty shell from a hard-boiled egg. We then are tasked on the reconstructive side with how to fill or reconstruct that area. We can use implants, and those can vary. They can be saline or silicone. That can be in 1 step or 2 steps. Or we can use patient's own tissue. The most common here is the first bullet, a DIEP flap, a DEEP flap. And in those patients that are candidates, we can select and utilize the patient's abdominal tissue. Where a patient may be an option to have a tummy tuck, we can take that tissue, prepare it, and then reconstruct the breast with that tissue. And those work very well for our patients. They're certainly more involved than the implant reconstruction, and there are, just like everything, there are some pros and cons to all of these procedures independently. We can reconstruct the nipple and the areola. We can do a smooth closure. This is something that patients aren't always aware of. There's been, I think since the New York Times article a couple of years ago, there's been a movement where some patients are choosing, and at varying stages in life, some young women and some older women, are choosing to not have reconstruction in that circumstance. For whatever reason it may be. It's very much a personal choice, right? But we'll perform what's called an aesthetic smooth closure. Certain techniques that we utilize allows the area to be smooth after the closure. So should the patient choose to wear a prosthetic, or should the patient choose to have a snug fitting shirt, they are comfortable and confident there aren't excess tissue in locations that aren't as favorable. And then also including nipple and areola tattooing. This is just, sometimes it's a little easier with imaging. When we're talking about DIP flaps, and right about here, the idea is that before the procedure for the patient, they're undergoing a surgical procedure of the breast. We're going to take this belly tissue that we would often remove from a tummy tuck, and we're going to prepare arteries and veins that flow into the tissue. However, we're leaving the muscle behind, and this is key. In the past, when this procedure originated about 40 years ago now, we were taking the muscle with it. Left a lot of patients with abdominal issues, whether it be bulges, hernias, inability to gently get out of bed without using their upper body because their core wasn't that stable. And so now we only perform just the skin and the fat with the artery and the vein, a little more involved. However, we'll preserve that and we will connect that in the breast. So it looks as though patients have their own tissue within the breast, and it doesn't behave like any other tissue, meaning if they were to gain weight, it would be larger. If they were to lose weight, it would be smaller. This is another option where sometimes patients don't have tissue to use from their belly. So sometimes we can borrow some skin and some fat with a little bit of muscle from the back. This is more often performed in my patients that are either a little more athletic or don't have abdominal tissue or tissue from their thighs that we can borrow to rebuild the breast. It's called a latissimus flap or a lat flap. Important factors. There's really no one procedure that is proper for all patients. It's hard to give a blanket procedure that works for all. I've listed here a series of bullet points that really delineate whenever we meet patients, whenever I meet a patient, we go through a thorough history. We want to know as much as we can about that patient to work with them to choose the best and the safest operation for them so they can have the most favorable outcome while reducing the risk of complications or headaches for them and their family. I find more and more that our patients are what we expect them to be, their daughters, their sisters, their mothers. But no matter where they fall in that category, they always seem to be the individual running the household. So in these cases, really the goal is to communicate to them the procedures, the options, how much downtime will be required, and what that means for their life and their family. Medications are involved. Radiation. So sometimes patients are candidates for radiation treatment, either after a lumpectomy or after a mastectomy. That factors into our thought process. If they are smoking, that's a big one. If patients are smoking, they really are at a substantial risk for more headaches and complications. So I'll work with patients to perform smoking cessation. They've used a variety of things, including medications, non-nicotine patches or non-nicotine other techniques, and gone so far as to use, my goodness, I'm blanking on it, more kind of Eastern style medicine approaches with other techniques that kind of reduce the risk of them continuing to smoke. Patients' weights and BMI can also factor into that. Acupuncture, my goodness. Acupuncture works well for patients for smoking cessation. So the role of plastic surgery in this, really, one of the biggest things is in 1997, I have to get the exact date, I think I have it listed in the next slide. But in the mid-90s, we passed a law here in the United States, a federal law, that basically required that insurance carriers allow patients to undergo breast reconstruction after a diagnosis. And so far as recent in the last like 7 or 8 years, we've actually improved that law to say that even though patients are entitled to it, they're not always being offered the opportunity to communicate with plastic surgeons. And so part of that updated law now declares that patients are to be given the option to see a plastic surgeon. No one's required to obviously see or seek someone for reconstruction. However, at times, our surgical oncology colleagues, for one reason or another, may not have always connected a patient who would be a very valid or great candidate for reconstruction with a plastic surgeon. And so now there's an obligation where the patients are presented with the information and the opportunity should they seek it out. A great majority of patients do. We're very fortunate in the Northeast. We have a healthy amount of us docs that perform procedures. So in more rural areas, I think the number is about 20 to 25% of patients undergo reconstruction at the immediate, meaning at the initial procedure with the oncologist. Here in the tri-state area, we're about 85 to 90%. And often the 10% that don't, it's very much through personal choice or selection. A couple of things to point out. If I'm a patient on the other side and I'm seeking a plastic surgeon, obviously we want to make sure that they're board certified. That just allows us to know that that doc has met the requirements that deem them to be not only safe, but also a high level of expertise in their position. When it comes to certain things like breast reconstruction, fellowships are often noted, and that means that someone has spent an extra year training in this at some point in their career. There are excellent reconstructive plastic surgeons that perform a great deal of breast reconstruction that are not fellowship trained, so this is not exclusivity, but it is one of the variables that in the last 15 to 20 years, docs that have done, for instance, I did my fellowship at Memorial Sloan Kettering, spent a full year performing breast reconstruction. And to me, that allowed me to learn a great deal about newer techniques that are available for patients and also how to help patients with the overall care for them. I think someone had asked me at some point to spend a few minutes on lymphedema. So lymphedema is, in essence, something that may happen to our patients that are undergoing either lymph node removal or lymph node sampling with a sentinel node biopsy, or having what's called a complete axilla lymphadenectomy. It basically is a big word for a great deal of the lymph nodes from the armpit are removed at the time of a mastectomy in an effort to help, number one, clarify the diagnosis of patients, and number two, with an effort to improve the chances of controlling the spread of the diagnosis. So everything's in a balance. In these circumstances, when patients have specific lymph nodes that are removed, that not only they may address the breast, but they may also address the arm. In those cases, the patients are at slightly higher risk of developing lymphedema. There are some compounding variables, meaning that patients that have a mastectomy, patients that have all of their lymph nodes removed from the armpit, and patients that have radiation. So though all three of those combined have a very high risk of lymphedema. Patients that have a lumpectomy, patients that have only a sentinel node removed, not all of the nodes, and patients that don't have radiation have a slightly lower risk, but it's not zero still. So in terms of treatment and options for lymphedema for patients that have been diagnosed, the first line of defense is lymphedema therapy or treatment from an occupational therapist or lymphedema specialist. They'll use compression garments, techniques of physical therapy, activity. And then the last line is potentially surgery. And I just basically provided the name of it here, but in essence, if you imagine lymphedema occurs because the lymph node is, in essence, an area where there's a channel to get from one road to the next. So the goal with lymphedema surgery is after the lymph node has been removed, that channel has been disrupted. So the road, instead of flowing straight, is now off kilt. Lymphedema surgery is intended to realign it or find a separate egress for that extra lymphatic fluid into, let's say, a vein in the nearby area. Often that's called lymphatic microsurgical preventative healing. So that's performed by those surgeons that are capable of performing that. It's pretty much part of what we all do on the reconstructive plastic surgical side that take care of breast cancer patients. And insurance coverage, it's interesting, 98, I thought it was 97, but I'll review it. So Women's Health and Cancer Right Act of 98 allows that for both total or partial, so lumpectomies or complete mastectomies are covered by insurance, as well as the opposite breast, in an effort to create better symmetry and make our patients more comfortable and confident after these procedures. And I think that's it.
If I had passed abdominal surgery, am I still a candidate for the DEEP?
That's a great question. Past abdominal surgery can have a wide range of what's performed. If a patient has had a tummy tuck or an abdominoplasty, or where anything where the tissue from the belly button to the pubic region has been removed in its entirety, that patient's no longer a candidate for a DIEP flap. However, patients that have had liposuction or have had C-sections or abdominal GYN procedures or general surgical procedures in the abdomen are very much often candidates still for a DEEP flap. They would benefit from a CAT scan to evaluate the blood supply to the area before any procedure was performed.
There's been news about implants contributing to certain kinds of cancer. Should someone with implants be concerned? And if yes, what should they do?
Terrific question. So there was recently an article that came out, but this dates back to a while ago where we became aware of what's called breast implant associated ALCL, anaplastic large cell lymphoma. And it was very specific to specific implants that have a textured outside shell. So implants that have a textured outside shell, and that was used historically to allow the implant to stay in place. From one specific company, Allergan, they used what's called a biocell texturing process. What they found was that in the long term, there were a small group of patients where they were developing lymphomas around the scar in the implant. These are very low-grade lymphomas. They often presented within the first 7 to 10 years, and they were very much treatable with strictly surgery, removing the implant and the scar, and patients were treated. Over the last several years, there's been about 5 new diagnoses of squamous cell carcinoma, similar to the skin type. What they think and what our oncology colleagues believe is that in those circumstances, those are patients that had something different within the scar. Again, it's around the implant and the scar. It's not specific to the implant. It's almost as though it's the reaction on the patient's side. Unfortunately, a lot of the information for those diagnoses doesn't tell us if they had textured implants, which can lend to that. Most patients, and I think most of us, I haven't used a textured implant in over 12 years. Um, Most docs usually don't use a textured implant given this information. There are some texturing processes and some implants that have never had an issue with anything around the implant. So it's a long-winded answer to your question. However, breast implants are still incredibly safe. However, it's important to know the type of implant being placed. So smooth is preferred over textured. And then also to just communicate with your doc. When at times patients have any concerns, I'll often just have them deferred to saline implants. We will avoid silicone implants so they, quote unquote, can sleep at night.
Are the textured implants, the Allergan, are they only silicone?
They had a saline implant, but that hasn't been available in over a decade.
For somebody that would come, like let's say it was your patient and they had an Allergan implant, would you tell them to remove them, or would you just monitor them, or what would you say to them?
Great question. So if they have a texture, so we sent a letter to all of our patients that have textured implants. If you have a textured implant, saline or silicone, and it's from Allergan's model, they used BioCell for texturing, those patients have the choice to have it removed. The FDA does not require it to be removed. The recommendation is to ultrasound, MRI on a more regular basis. To me, that's 3 to 6 months. Some people think a year. I'm a little on the neurotic side, so 3 to 6 months was right.
Okay.
But it is covered. A good deal of patients did request to have the implants replaced, and that is covered through insurance.
Okay. Next question. Is there an alternate treatment to surgery for lymphedema?
So treatment for lymphedema really is, the first line is, as I mentioned earlier, it's physical therapy, it's compression garments. And that what that does is basically just allow our patients to not feel the effects of lymphedema as much as they might without it. Outside of surgery, there's no therapy for lymphedema, so there's no medication or oral therapy that will treat lymphedema. There are different types of surgery that we've used to treat lymphedema. I mentioned the most common, where we connect a lymphatic vessel with a vein, or lymphatic to lymphatic, and that's the lympha. However, we also do what's called a microvascular transfer, where we borrow 2 or 3 lymph nodes from, let's say, the lower abdomen, and we transfer that into the patient's armpit in an effort to reduce the amount of lymphedema.
Thinking about post-surgery and healing, do you recommend physical therapy for patients that have had a mastectomy and are starting reconstruction?
Yes, I'm a big physical therapy proponent. I will say that I refer to about 3 or 4 organizations that are very breast specific. So not all physical therapists are aware of limitations that patients may have that are undergoing either tissue expanders, so expansion, that are undergoing the deep flap or other reconstruction. It's important to find someone that's breast reconstruction specific on the physical therapy side.
Okay. If I am unhappy with my reconstruction results, does insurance cover doing it again or fixing?
Yeah, they do. There's no timeout, meaning window of time where you can't have a revision to the reconstruction. And there's no numbers. In other words, if one patient takes 2 procedures to get it correct, another patient takes 4, you don't get dinged, because there's a lot of variables that go into it. The diagnosis initially, the mastectomy, the reconstructive option, how a patient's heal. So all of those variables factor in. I've had patients that have had several procedures before they met us, and they still had a procedure with us to help rebuild or reconstruct. That's covered.
What are your thoughts on having the deep flap 5 months after radiation?
Great question. So my requirement is 6 months. The literature supports as early as 3 months, although there are more complications at 3 months. 6 months is that middle zone where there is less complications, but patients don't have to wait as long. And I will tell you, there are some of my colleagues, and there's some literature from about 8 or 9 years ago that supports 1 year. So you can run the whole gamut based on who you ask. I'm a 6-month person just because of the literature and my experience in the past.
How do you feel about lymphatic massage?
I'm pro-lymphatic massage. I use it not only for breast reconstruction, but also for, let's say, my cosmetic procedures, abdominoplasty. All of my patients go for lymphatic massage after.
Okay. And is there anything you could do to avoid lymphedema before it happens?
Yeah, it's a great question. Unfortunately, we don't have any methods for avoiding it.
What does post-op look like, time and support wise?
So it'll vary based on the procedure that a patient's undergoing. For patients that are having a lumpectomy with reconstruction, even without, honestly, it's in the 3 to 7 day range of recovery. So I request that most patients take off a full week after a lumpectomy. If patients are having a mastectomy, that's a larger procedure. In those circumstances, I recommend about 2 to 3 weeks of recovery, meaning off from work. And if they have a job that allows some lifting, pushing, pulling, or requires some lifting, pushing, pulling, I would recommend a full month after mastectomy.
Do you go with reconstruction, do you go straight to implant or use expanders? What is that process like?
Yeah, it varies from patient to patient, and it varies based on two real factors. Number one, if the patient has enough blood supply to provide enough blood supply to the skin, the outside area after a mastectomy, then I would consider above the muscle. However, sometimes patients' breast tissue sits very closely to the skin, which leaves the skin a little more tenuous. In those circumstances, I tend to be conservative and err towards behind the muscle. When given the choice, above the muscle is a bit of a faster recovery. I would always select it, but it has to be in the correct context.
For under the muscle, is that like for the expander, how does that, so like if it's under the muscle, is that something that it's more prevalent to need to use the expander, or it doesn't work like that?
No, it's a good question. So under the muscle, I think is probably about still 75% of reconstruction. For me personally, above the muscle is about 20 to 25%. And that's based on patient selection. It's based on volume of the breast. Smaller breasts tend to have a little more success above the muscle. Larger breasts above the muscle sometimes creates a bit more of a surface area with fluid collection, headaches, and complication. And so the literature really is starting to show that we should be cautious in those circumstances. But behind the muscle, and if it's an expander, it's about 80% of the nationwide reconstruction.